Good afternoon, Brown alumni, parents, and friends. My name is Josh Taub, Brown class of 1993, and I am the Assistant Vice President for International Advancement at Brown University. It is my great pleasure to welcome you all today. I hope that everyone is doing well and, most importantly, feeling healthy. Thank you so much for joining us from around the world for the first iteration of our International Advancement webcast series. This one with Dr. Adam Levine, Director of the Center for Human Rights and Humanitarian Studies. Thanks to all of you for taking a moment out of your busy day to continue engaging with Brown and to participate in this new virtual life of the university. We are grateful to be able to continue bringing everyone together in these challenging times in support of the university and of our students. With that, it is my pleasure to tell you a bit more about our speaker, who is an expert in pandemics, emergency rooms, and humanitarian responses. Dr. Adam Levine is an associate professor of emergency medicine and director of the Division of Global Emergency Medicine at the Warren Alpert Medical School at Brown University. He currently serves as the director for the Center for Human Rights and Humanitarian Studies at our Watson Institute for International and Public Affairs, whose mission is to promote a just, peaceful, and secure world by furthering a deeper understanding of human rights and humanitarian challenges around the globe, and by encouraging collaboration between local communities, academics, and practitioners to develop innovative solutions to these challenges. Adam Levine also serves as the primary investigator for the Global Emergency Response and Recovery Partner Engagement Cooperative Agreement between International Medical Corps and the U.S. Centers for Disease Control and Prevention, which is focused on improving international and local capacity for responding to epidemics and pandemics. His own NIH and foundation-funded research focuses on improving the delivery of emergency care in resource-limited settings and during humanitarian emergencies. In recent years, Dr. Levine has responded to humanitarian emergencies in Haiti, in Libya, in South Sudan, and Liberia, and has led research and training initiatives in South Asia, East Africa, and West Africa. Dr. Levine was on the front line of the Ebola crisis in 2014 and helped find effective treatments back then. He is now working with a global relief organization to ramp up the medical response to COVID-19 in high-risk countries. So for today, Dr. Levine is going to take a few minutes to share with us the work of the Center for Human Rights and Humanitarian Studies, and then he will offer remarks on COVID-19, applying lessons from the fight against Ebola. If you have any questions during or after his remarks, please post them using the Q&A button at the bottom of your Zoom screen, and following Dr. Levine's remarks, I will do my best to select questions and ask them on your behalf. So once again, welcome to our international alumni, parents, and friends, and without further ado, please join me in virtually welcoming Dr. Adam Levine.
Thank you, everyone. It's wonderful to be here. As Josh was mentioning, my own career has brought me to work in a number of humanitarian settings around the world. Over the past decade, I've worked in disasters such as the Haiti earthquake, the conflict in Libya, refugee crises in South Sudan, and of course, the Ebola outbreak in West Africa. And in those experiences, working in the field with different humanitarian organizations, I began to recognize that one of the major gaps was a lack of evidence and professionalization in the humanitarian field. In many ways, humanitarians were working in the way doctors worked 50 years ago, doing things based on anecdote, based on what they were taught, but not based on what had been shown or proven to be most effective and best for the patients in front of them. So it was about 4 years ago, with the support of the provost at Brown, that I was able to launch the Humanitarian Innovation Initiative at Brown University within the Watson Institute for International and Public Affairs. And over the past few years, we built up that initiative through a number of research and training projects, and we're finally able to raise an endowment last year to make our Center for Human Rights and Humanitarian Studies official. It was just launched in the fall, and I'm the inaugural director for the center. And the core mission of our Center for Human Rights and Humanitarian Studies is to promote a more just, peaceful, and secure world by, number one, furthering a deeper understanding of global human rights and humanitarian challenges. So studying these and understanding what the challenges actually are. But then perhaps even more importantly, encouraging collaboration between local communities, academics, and practitioners to develop innovative solutions to these challenges. And we really believe that it's at the nexus of bringing together academics from various disciplines here at Brown with humanitarian and human rights practitioners in the field, with the organizations that are doing this work day to day, and with local communities that are experiencing disasters, conflict, human rights abuses, bringing them all together in order to identify solutions that are context appropriate and sustainable in settings around the world. So in terms of the objectives for our center, we work in a number of different arenas. Number one, as an academic center, we promote rigorous interdisciplinary research in both human rights and humanitarianism. And as I'll point out, we have a number of different federally and foundation-funded research streams going on. We're also, of course, as an academic entity at Brown, really determined to reimagine the education and training of the next generation of humanitarian and human rights researchers, educators, and responders, both at Brown and through training and professionalization programs around the world. We develop programming that engages faculty, visiting scholars, and practitioners from communities around the globe to explore current crises and share best practices. And then, of course, we have a strong focus on our students, both at the undergraduate, graduate, and medical level, to become engaged in human rights and humanitarian work through specific action learning opportunities that I'll mention in a second. And finally, and perhaps most importantly to this group, we are really excited to leverage our rich alumni network to support the work of our center. We understand that we have alumni all across the world who are working in the human rights and humanitarian arenas, and we really want to bring them back to Brown to provide mentorship, professional development, and inspiration to our students, as well as partnerships with our center for exploring new research and training opportunities. So as mentioned, I'm the director of our center. Our program manager is Seth Stoolin, and then we have a advisory board of 16 leaders and innovators representing international humanitarian and human rights organizations and institutions, from the leaders of organizations like Human Rights Watch and the International Crisis Group, UN agencies like UNOCHA and the World Health Organization, and a number of different humanitarian NGOs like Save the Children, Doctors Without Borders, AmeriCares, etc. We also have about almost 20 affiliated faculty from across Brown University who are doing research or training in the fields of human rights or humanitarianism. And those faculty span the disciplines from medicine to public health to the social sciences, including economics, political science, anthropology, sociology, history. We really feel that both human rights and humanitarianism require an interdisciplinary lens to understand the complexities associated with them. And we work whenever possible to bring faculty together from different disciplines to attack these problems. And then we also have 50 global fellows. These are early career to mid-career academics and practitioners based in universities and local organizations across the global South that really provide for us a close connection to local communities and partner with us on a number of our research and training projects. So don't have time to go over all of our work, but I just wanted to give you a brief snapshot of some of our primary initiatives in both the research and training arena. So on the research side, we have had a number of projects in related to civilian military coordination in humanitarian response. We have a large grant right now from the US State Department, as well as grant from the Carnegie Corporation of New York, looking at how humanitarian and military actors coordinate or don't within the context of both conflicts and disaster scenarios, and also looking at the perception of local communities regarding the work of military in different disaster and conflict settings. We also have a grant from the Gates Foundation looking at development of mobile health tools for helping practitioners and clinicians on the ground respond to epidemics of cholera and other diarrheal diseases, and providing them with decision support so that they can provide better care for their patients. In addition, we have a whole host of different research seed grants. These are in partnership with our global fellows around the world, looking at all different aspects of humanitarian response, from building better communication tools in humanitarian settings to better understanding the dynamics of local communities and the role of religious organizations in humanitarian response. And you can certainly look at our website, which I'll share at the end, for a whole list of all of our different seed grant projects around the world. On the training side, we have led a number of successful trainings, both at Brown and regionally around the world, on humanitarian field programming. And then we also have a big project that I'll talk about in a moment with Project Hope, related to COVID-19 specifically. Of course, based at Brown University, students are one of our primary missions. And so we work in all of our different activities to engage students. We have students involved in all of our research and training projects. Then we also have a number of specific programs specifically for students. Our Hack for Humanity event has been one of our most successful programs. Each year we bring together somewhere around 70 to 80 students who work in teams to develop proposals for innovative solutions to humanitarian or human rights challenges. They get to pitch those solutions, and then we fund the top ones to be able to go on to develop their projects. We also have a number of research assistant positions, paid internships that we do with leading humanitarian and human rights organizations. This is through a grant we have from the Hearst Foundation. We're able to actually provide students with funding to be able to do internships around the world. And this is really key because it gives students who come from disadvantaged backgrounds, who may not have the ability to go work for free for a summer in New York or Geneva, the capacity to do that with funding from us. And then of course, our faculty teach a number of courses. We have seminars and lectures as well geared towards students. So specifically with regards to COVID-19, of course, when the pandemic struck in January and February, our center immediately began to think more about how we could respond in an effective way using the resources that we had at our disposal. We immediately created a COVID-19 resource hub, which you can find on our website, with guidance for professionals, situation reports, dashboards, all intended to help the Brown community, whether it be researchers, practitioners, better respond to the pandemic in whatever function that they were working in. We also worked on a number of public education, including media interviews, webinars, et cetera, to raise awareness about the pandemic and ways that people could work to protect themselves and others. And then finally, we partnered with Project Hope, one of our long-term humanitarian partners, to launch a training of the trainers for health professionals around the world. And so this was recognizing that one of the huge gaps, especially in low and middle income countries with regards to COVID-19, was frontline health worker preparedness and training to be able to respond to this pandemic. And so we worked with Project Hope and with their local country offices in a number of countries around the globe to develop a remote online training of the trainers program. This includes 8 core competency modules accompanied by a training manual, case exercises, training videos, exam templates, and real-time Q&A support, and has been translated into Spanish, French, and several other languages. Our faculty at Brown deliver these trainings to pre-selected health leaders in each country around the world that we've delivered the training in. These health leaders are usually heads of hospitals or heads of local health departments, and we train them essentially to be able to deliver this training to others in their local community and to adapt the training to their local needs. The delivery has been over the Zoom platform, which has given us the opportunity to be able to reach all corners of the globe with this training. It's usually delivered over 3 to 4 days by Brown faculty to these health leaders. And we work really hard to try and adapt the training to the local needs of the specific country where we're delivering it. And then we're following a cascade approach where at the end of this training, we pass on all of these materials to the health leaders that we've trained so that they can go on and train others within their local communities. So in total, the impact so far has been that we've conducted the training in over 22 countries. We've trained over 900 health leaders through our TOT curriculum, and those health leaders have gone on to train 23,000 frontline health workers through their cascade training. And highlighted here are some of the countries around the world where we've conducted the training. As you can see, it spans the global south, especially Latin America, Africa, Eastern Europe, South and Southeast Asia. And in many of these cases, we've been able to prepare frontline health workers in advance of the wave of COVID-19 before it's hit their countries in large numbers. And we found through pre and post test trainings a 15% average improvement in core knowledge after completing the TOT. In most cases, the participants' knowledge goes from somewhere in the 60 to 70% range to the 80 to 90% range on the core attributes of how to prevent and respond to COVID-19. So our center is new, but it's also really one of a kind in many different ways. To our knowledge, we are the first combined center for human rights and humanitarian studies in the world. That gives us a really unique opportunity to look at the areas of interaction between these important topics and really bring a rights-based approach to humanitarian action. Number two, while there are dozens of centers for human rights at major universities across the US and Europe, and a handful of centers for humanitarian studies at major universities around the world, the vast majority of centers for human rights are based in law schools. The vast majority of centers for humanitarian studies are based in schools of medicine or public health. And by being based at the main campus, as we are within the Watson Institute for International Public Affairs, we really have the opportunity to bring an interdisciplinary lens to the issues that we are studying and teaching on, to be able to bring together faculty, not just from law and policy, but also from engineering, from public health, from medicine, from all of the different social sciences, from sociology to economics, and even from the arts and from design. We have faculty in all of these areas who are contributing to the work of our center. So that was the brief intro that I wanted to give to you about our center. And now I wanted to move into the topic of the day, which is going to be around COVID-19 and the lessons that can be learned from my work during the Ebola epidemic. So I'd like to start here. This is a picture of Phoebe Hospital, which most of you have probably never heard of. Phoebe Hospital is a major hospital in central Liberia. It is known as one of the better hospitals in Liberia. It serves as the training ground for Cuddington University, which is one of only 2 nursing schools in Liberia. And it was here on June 23rd of 2014 that a patient walked through the door here that goes into the emergency department of Phoebe Hospital. The patient had fever, some nausea and vomiting, looked fairly ill, and the nurses and doctor working in the emergency department thought about a number of different possible diseases. They thought maybe this could be malaria, this could be typhoid, diseases they were very familiar with. They gave the patient some antibiotics. They checked some blood tests on her, and they admitted her to the hospital. It could have been a totally routine case and would have been, except that a couple days later, the patient died. And what was particularly strange was that a few days after that, several of the nurses caring for the patient started to fall ill themselves. And in total, 7 nurses would become sick and 6 of them would die. That ran shockwaves through the staff at the hospital. Many of the other hospital staff became concerned and stopped showing up to work as they saw their colleagues falling ill, and the patients in the hospital as they saw the health professionals no longer coming to work and saw their fear. Those who could get up and walk did just that. So within the course of a few weeks, the hospital was essentially empty. All of the staff and the patients had left. But it didn't end there. This pattern repeated itself at health centers and hospitals across the county, and then soon across the entire country of Liberia. What nobody at the hospital that night or in the days after recognized was that an outbreak of Ebola had already begun in Guinea, just a few hundred miles to the north of this hospital. And they'd failed to perceive that this outbreak could have spread to their doorstep. They had failed to recognize the signs and symptoms of Ebola and to take the proper precautions to ensure that it hadn't spread through their health system. Similarly, as nursing staff became sick at Phoebe Hospital and the surrounding hospitals, Cuttington University, which I had mentioned is one of only 2 nursing schools in the country, made the decision to shut down. And pretty soon after that, most of the other universities in the country, as well as all of the elementary and secondary schools, also shut down to prevent the spread of Ebola through their networks. The Ministry of Health and Social Welfare in Bong County and similar local ministries of health across the country soon began diverting all of their resources towards the fight against Ebola. And in doing that, it meant that all of their other activities that they had been doing prior to that, things like treating malaria in children, vaccinating children against measles, identifying and managing malnutrition in kids, all of those other activities stopped. And so by the time I arrived in Liberia in August of 2014, all of the hospitals and clinics in the entire country were shut down. There was no place to get medical care, and all of the public health infrastructure had been redirected towards fighting Ebola. There were no public health measures being used to prevent or treat other diseases. And so as a result of that, it meant that anybody who got into a car accident in Liberia had no place to go. A woman who had a difficult labor had no obstetrician to see in order to help deliver that baby. And so the consequences of this disease were far greater than simply the impact on individuals, but an impact on the entire healthcare system and economy of the country and its neighbors. I want to contrast that with another hospital. This is the first consultant hospital in Lagos, Nigeria, exactly 1,000 miles away from Phoebe Hospital in Bong County. And it was through the doors of this hospital exactly about 5 weeks after that patient first walked through the doors of Phoebe Hospital, another patient walked through the doors of this hospital. The patient was a traveler from Liberia to Nigeria and had been feeling ill on the flight over and was brought to this hospital. Was brought to this hospital actually because the main public hospital in Lagos, the doctors were on strike that day. And so airport officials brought the patient to this hospital. And the patient was lucky enough to see Dr. Stella Adadova, a local practitioner at this hospital, who immediately identified the patient's symptoms as being possibly due to Ebola, and quickly quarantined the patient, started resuscitation and treatment for the patient based on what was known about Ebola at the time. As a result of her actions, what could have been a horrendous outbreak of Ebola in Lagos, Nigeria, a city of 26 million people, ended up never spreading outside the walls of that hospital. Dr. Stella herself would become infected with Ebola from her contact with that patient. Several other nurses and health workers in the hospital would become infected. And Dr. Stella herself died from Ebola as a result of that interaction. But because of her actions, the disease never spread outside of that first consultant hospital. And the city of Lagos of 26 million people was spared what could have been hundreds of thousands, if not millions of deaths as a result of the disease. And so this tale of two hospitals, I think, really illustrates what for us needs to be kind of foremost in our minds when we think about global pandemics of emerging infectious diseases, which is that our global system for protecting all of us around the world from these new emerging and re-emerging pathogens that we're going to continue to see over the coming decades, our entire global health security system depends on an individual doctor or nurse working in a small clinic or hospital somewhere in a low or middle income country, being prepared and being able to identify that disease, to institute proper infection prevention and control procedures to prevent the spread of that disease, and to quickly alert authorities. And if that capacity isn't there, then the disease will spread and will spread fast enough that we may not be able to actually tackle it, even with the might of all of our millions and billions of dollars, and even with the might of all of our technology and tools, if we can't stop it where it starts quickly. And if we don't have a trained health workforce all across the world, then we're going to be dealing with what we're dealing with now in terms of the COVID-19 pandemic. So I think it's worthwhile to talk a little bit about what happened in West Africa in 2014 and 2015, and how it was similar to what is going on now with the COVID-19 pandemic, but also importantly, how it was different. And in fact, how it was ended quickly before spreading much beyond the borders of the three most affected countries in West Africa. So it wasn't necessarily because the World Health Organization or the global health community took rapid action. In fact, the disease was first detected in March of 2014 in Guinea, and it wasn't until August 8th that the WHO declared it a public health emergency of international concern. Not only was this 5 months after the disease was first detected, it was several months after it had already spread to a number of other countries in West Africa. And it was really only when first cases began to appear in Europe and the US that the WHO moved quickly to declare it a public health emergency of international concern. And I think this is an important lesson that WHO learned. And in fact, in the aftermath of the Ebola epidemic, the World Health Organization really worked to reorganize their infrastructure for response to major epidemics and pandemics. They created an entire health emergencies program, which is bent towards surveillance and detection, especially early detection of public health emergencies such as pandemics, and also training and fortifying local healthcare workers to be able to respond to it. In this case, with the COVID-19 pandemic, it was only about 4 weeks from when the disease was first reported to WHO to the time when they declared it a public health emergency of international concern. And so a much faster response time and a much more serious and robust response by WHO than we saw in the Ebola epidemic. So overall, by the numbers, the Ebola epidemic obviously was much smaller than the COVID-19 pandemic. In total, just under 30,000 people were infected, mostly in Liberia, Sierra Leone, and Guinea, though there were sporadic cases across Europe, the US, and other African countries. About 11,000 died, which is a case fatality ratio of around 63%, orders of magnitude higher than COVID-19. So COVID-19 kills less than 1% of people infected. Ebola kills more than 50% in general. The health worker population of Liberia, Sierra Leone, and Guinea were decimated. And this just goes to show that with any emerging infectious disease, it's really health workers who are not only the best line of defense in terms of detecting it early, but they're also the ones who are most in danger of getting sick and dying themselves because they have the most contact with ill people and therefore the most likelihood of getting infected themselves. And when I say decimated, I actually mean that in the true sense of the word. 1/10 of all the health workers in Liberia and Sierra Leone were killed by Ebola during the West Africa epidemic. But as I mentioned earlier, there was also this untold number of secondary deaths from other diseases that occurred. And in the aftermath of the Ebola epidemic, a number of individuals went back and did research studies. There was a lot of mathematical modeling. And the predictions I've seen range from anywhere from 100 to 200,000 people who died from other diseases, especially diseases like malaria, childbirth, as a result of the healthcare system being overwhelmed and shut down by Ebola. That's more than 10 times as many people as actually died of Ebola itself, died of these other diseases. And in fact, we are seeing that now with COVID-19 as well. In the United States, the numbers suggest that at least as many people are dying of other diseases because of the overwhelmed healthcare system and fear of accessing healthcare as from COVID-19 itself. And in low and middle income countries, I imagine that those numbers are going to be much higher, probably more similar to what we saw in West Africa. But as bad as West Africa was, it certainly could have been far worse. When I arrived in August of 2014 to work with the humanitarian organization International Medical Corps to establish their response, shortly afterwards, the CDC came out with projections that suggested up to 1.4 million total cases of Ebola by January of 2015 in Liberia and Sierra Leone alone, if nothing was done. If you read farther through the report, though, they also said that it could be limited to just 35,000 total cases by January of 2015 if proper isolation and treatment for most Ebola cases was put into place. And in fact, at the end of the day, that's really what we saw. It was that second projection that came out to be true because of the really robust local and international response that really worked to ensure that well over 50–60% of all cases were being identified and isolated. So what actually allowed for the response to be as robust as it was? What allowed for us to contain the Ebola epidemic in a way that we have not been effective at containing the COVID-19 pandemic, at least globally? And so it's really very simple. It's this four-legged stool of health promotion, contact tracing, testing, and clinical care / isolation. These four components of the outbreak response during the Ebola epidemic are the four major components of every single major outbreak response that I've ever been part of or that anyone's ever been part of in the history of responses to pandemics. And if done correctly, these four different components are effective at reducing the spread of a disease, and in the case of emerging infectious diseases, in the case of epidemic-prone diseases, ending the epidemic and bringing it under control. And so, many people will discuss and argue, and in the aftermath of the Ebola epidemic in West Africa, many people argued about which of these four components were most important. And you hear people kind of arguing about that today during the COVID-19 pandemic. They argue about which is most important, if any of them are important. And I will tell you that that is similar to arguing about which leg of your chair is the most important leg of your chair. In the end, the chair doesn't work unless it has four legs, and the response to an outbreak doesn't work unless you have all four of these components working in concert from the very beginning. And I'll talk a little bit about each one and what was done well, what could have been done better in the Ebola response, but also how it compares to the way that these are being rolled out in the current response today. So first is health promotion, and health promotion is really about educating communities and the population at large about a disease, especially when it's a new or emerging infectious disease like Ebola, like COVID-19, that people are not familiar with, that they haven't heard of before. And this was actually done quite well in Liberia when I was there. You had not only billboards that were up everywhere, but more importantly, you had radio advertisements. This was a major way that people who didn't have access to television or internet necessarily, this was a major way they got information, was through local community radio. And the Ministry of Health and the local communities did a really good job of running health promotion ads on the radio. And in fact, they created different songs about Ebola. There was a rap song about Ebola. There was a reggae song about Ebola. There was a children's song about Ebola. While I was there, there was a pop song about Ebola that was top of the charts in Liberia. And all of this information was able to get to communities. In addition to that, religious leaders and others were able to act as force multipliers, educating their congregations and their communities about the disease. And so what do you need to educate people about? What were people educated about? So really basic information. So what are the symptoms, how to prevent it, how to manage it. This is information people need to know. Also, how to protect themselves, personal hygiene, hand washing, surface disinfection, facial awareness. We each touch our face many, many times every single day, and coming to an awareness of that helps reduce the likelihood that we're going to bring a disease from our fingertips to portals of entry into our body. And then social distancing, so reducing touching. So Liberia, like many communities around the world, a community culture that involves a lot of touching, hugging, shaking hands, etc. Getting people to stop shaking hands to switch to sort of other means of greeting was really important. Decreasing mass gatherings, closure of schools with small children who are not able to sort of avoid touching each other. These were all sort of important components. You'll notice nowhere on this list are lockdown or shelter in place. Those are not activities that have ever been used for any pandemic response in the history of pandemics before COVID-19, and they shouldn't be part of a normal pandemic response. If you do everything else right, there's absolutely no need to do that. And it was only the breakdown and the failure of our ability to complete the 4 objectives for outbreak response for COVID-19 that we were left to create these lockdown scenarios that have destroyed so many of our economies in the rich world, yes, but much more importantly, in low and middle income countries around the world. And the goal of all of these strategies is really one of flattening the curve, as you say, basically community mitigation, slowing the spread in a community. Health promotion by itself is never going to end the epidemic, but it can slow the spread in the community, and it can give you the opportunity and the time to implement the other measures and make it easier for the other measures to be effective. And so what are those? Those include contact tracing or surveillance. Just a couple quick definitions. When we talk about isolation, we're referring to patients who have symptom of the disease, so keeping those people separate from others. When we talk about quarantine, we're really talking about asymptomatic contacts of people who have the disease. And quarantine means having those people separate themselves from the community, even though they have no symptoms, simply because they've had contact with someone who's had symptoms. There is passive surveillance, which is what has largely been used during COVID-19. It's about people self-reporting when they get sick. It's about hospitals reporting the number of cases they're seeing. It's about local ministries of health reporting the number of cases that come to them. And as a passive system, it can help us understand the spread of a disease in a population. It can help provide for data that can be used for modeling, but by itself, it's not going to be able to stop the epidemic. What you really need is active surveillance, or a nicer name for that is contact tracing. And contact tracing is really a system of identifying every symptomatic case, and that's where testing comes in, where we can actually ensure that we identify those symptomatic cases, and then asking them simply who all of their contacts have been since they became ill. Finding those contacts and having those people quarantine until they've passed the incubation period of the disease. And that by itself will ensure that if it's done well, the disease doesn't propagate and spread to others. Because in fact, the highest and most important risk factor for getting a disease, whether it be Ebola or COVID, is contact with somebody else who's had the disease. And then comes testing and clinical care. Testing is not easy for a new or emerging infectious disease. Often you have to develop a whole new laboratory test from scratch because we haven't had that disease and haven't had to test for it before. But with new technologies, actually, this is becoming much more rapid of a process. And within a few months of the Ebola pandemic beginning, we had a system in place for PCR testing for Ebola, and we were able to implement that pretty well in order to contain the epidemic. In COVID-19, we did have tests that were available within a month or two of the initial identification of the disease, which is incredible from a technological standpoint. And it's truly a shame on us, and by us I mean those countries such as the UK and the US, which failed to implement the test in high numbers. Other countries around the world did, and were able to use that to contain the epidemic more quickly. And then lastly, clinical care. I mean, one of the worst things you can do is tell people there's a scary new disease, that it has a high mortality, and by the way, there's nothing we can do for you. It's incredibly important to ensure that you have the systems and capacity in place to care for people who are becoming ill. And that meant in the case of Ebola, ensuring that we had enough Ebola treatment centers to care for all of the people. But importantly, the Ebola treatment centers also acted as a way of isolating individuals who are sick from their communities in order to reduce the likelihood of them transmitting the disease to others. In the span of 6 months, we built, and by we, I mean the local Ministry of Health and the international community, built 60 Ebola treatment centers across West Africa and more than 25 laboratories that were capable of testing for Ebola. And this is a huge accomplishment in a very short period of time. It was this, along with the incredibly strong health promotion and contact tracing systems that the local ministries of health set up, in combination together, this is how we were able to stop the Ebola pandemic in a matter of months. I mean, literally from when the humanitarian response really geared up in the fall of 2014 until when cases were largely under control was probably about 6 months. And it was truly just because of this response that we were able to do that. So, I'm kind of running low on time. I'm gonna sort of skip out on a lot of the rest of this talk, which is just a little bit more about the details of what that response kind of looked like on the ground, but instead really try and open it up to questions that folks might have.
Thank you, Dr. Levine, for your fascinating remarks. So as you just mentioned, we are going to open it up now for Q&A. And I want to encourage all attendees with questions to submit these with the Q&A button, which is at the bottom of your screen. And to start with the first question, one attendee congratulates you on launching this incredible Center for Human Rights and Humanitarian Studies. You mentioned in the first part of your talk, when you were reviewing the center, that there are opportunities for students, as per Brown's philosophy and tradition, to be very active with the center. And you mentioned, I think, the Hearst Fellowships as one example. Could you say a bit more about how students engage with the center and what opportunities exist for students to work with you and work with the center and engage in research?
Absolutely. So we have students engaged in a number of different ways with the work of our center. I mean, number one, at a very basic level, our faculty teach a number of courses at Brown related to human rights or humanitarian topics, and those are incredibly well attended by students. We are working towards the development of a new certificate in human rights and humanitarian studies in line with the new certificate program that Brown has launched, which is similar to a minor at other universities, where students can have their primary concentration, but also have additional expertise in another area. And so we're working to develop that for students who might be in engineering, might be in political science, might be in public health, but want to have that additional expertise in human rights and humanitarianism before going off into the work that they want to do. We are also have student research assistants on almost all of our different research projects. So students engage with our faculty who are leading different research projects to help with everything from literature reviews to data collection, kind of depending on the project. And it's a really great way for students to actively learn how to do research in this arena and how to become involved. You mentioned the student internships. So we have partnerships through our advisory board with more than a dozen different human rights and humanitarian organizations and UN agencies around the world. And we've long worked to set up internships for students with these different organizations and others. But now one of the differences is that we have funding through a grant from the Hearst Foundation to actually provide for paid internships so that students can do a summer internship with a leading humanitarian or human rights organization. Almost always these internships are typically unpaid, but we can provide them with funding to cover housing and food and travel so that they are able to actually do the internship in an area that they are passionate about, rather than taking a low-wage job during the summer in order to make ends meet, which is what many of our students from less advantaged backgrounds have had to do during their summers. And this has been incredibly popular. We launched it last year with 5 internship spots and had more than 100 students apply for these 5 spots. And we do hope to be able to expand it in the future with additional funding from foundations and donors. And then finally, as I mentioned, our Hack for Humanity event is kind of one of our big engagement events for students each year. We had more than 70 students participate this last year in a Hack for Humanity that was focused on refugee health, and came up with some really incredible, innovative ideas. We're funding 2 of them right now to go forward to develop those ideas and further and test them out in the field.
Thank you. We have an alum, Alfredo Ayala, who's joined us from the Philippines. A greeting to you and to others in the Philippines. Alfredo asks how the high rate of asymptomatic COVID cases changed the necessary response versus Ebola.
Yeah, it's a really good question. And part of the truth is we don't actually know the exact percentage of asymptomatic Ebola cases. There actually probably were a lot more than we knew at the time. And antibody testing that has been done in West Africa since the epidemic showed us that many more people have antibodies to the disease than were ever diagnosed as cases. And so we do think there was a large portion of asymptomatic cases of Ebola as well. Every disease has a spectrum in people, from very severe disease to mild disease to asymptomatic. But certainly it has been an important issue for COVID-19. At the end of the day, those asymptomatic patients got it from somebody else. And so if you are identifying the symptomatic cases and quarantining all of their contacts, many of those contacts that you're quarantining are going to end up being asymptomatic cases as well. And so by quarantining those people, you're preventing those asymptomatic individuals from spreading it to others. And one of the things that's really important to note, and this is really lucky for us, is we don't have to get the system perfect. We don't have to identify every single case. We don't have to quarantine every single contact. In fact, with a disease like COVID-19, which spreads on average from 1 person to 2.5 other people, this really means that we just have to reduce that rate of spread from 2.5 people to less than 1 person in order to end the epidemic. Because obviously if each person is spreading it to less than 1 other person, the epidemic will eventually end. This means that we really only have to quarantine and isolate 60 to 70% of cases, whether they be symptomatic or asymptomatic, in order to stop the spread of the epidemic. We don't have to get it 100% correct. And that's very lucky for us. You have another disease like measles, where on average 1 person spreads it to 15 other people. You have to actually be isolating and quarantining upwards of 95, 97% of people. That is very difficult to achieve, if not impossible, which is why a vaccine is really the only way to control measles, and a highly effective vaccine that's more than 90% effective is the only way to control measles. But with diseases like Ebola and COVID that don't spread to as many people as quickly, we have the opportunity to implement the contact tracing and isolation measures and be able to control the epidemic that way.
The second part of this question is, what are the most promising new testing approaches, for example, ELISA or pooled PCR, that might be game changers for the fight against COVID-19?
Yeah, I mean, certainly we are seeing new tests arrive on the market every single day. Some of these have been well studied and some have not. And I think that is, one of the sort of cautions I have to put out there. I am on the Healthy Fall 2020 task force that President Paxson set up to figure out how Brown University restarts its coursework and brings the university back in the fall. And it's been one of the important challenges that we've had, is sort of separating out the hype from the reality. And when you read the news, and that's your only source of information, you might see lots of new tests, lots of new treatments that are very exciting. But when you delve into it, you realize that most of these have not been well studied, cannot possibly have been well studied, because there simply hasn't been the time to study them. And so we do have to be careful to make sure that when it comes to new tests, that they're actually compared to a gold standard and studied to ensure that they have high enough sensitivity and specificity to be really useful. But certainly more tests are being developed and good ones are coming out. We have the standard PCR tests, which basically involve a nasal swab, a somewhat uncomfortable nasal swab, as it might be, that can tell us if someone is currently infected with COVID-19. But then we also have the antibody tests, which are done with a pinprick of blood, or a little bit more blood, that can tell us whether somebody was previously infected with the disease and may even possibly be immune now, though we don't know for certain about that. And so, these two different types of tests can be used in a lot of different ways by, a university like Brown, by a corporation, by a country, to figure out sort of the pace of the pandemic and figure out how to adjust their testing and contact tracing strategies based on the percentage of people in those different groups in their population. There are newer sort of tests that are less invasive. Most of them are less sensitive as well. And so we have to be careful when we're using them for a diagnostic purpose, like to decide if that person in front of us has COVID or not, but they could be very useful from a surveillance purpose. So for instance, at Brown, one of the likely things that we'll be doing going forward is two-tiered levels of testing. We'll be doing traditional PCR testing with nasopharyngeal swabs for all students, faculty, and staff who are showing symptoms of the disease. And these are the highly sensitive tests that can tell us for sure whether this patient in front of us has the disease and needs to be isolated or not, which is a really important decision. But then we're also going to be doing surveillance testing using some of these less invasive means on portions of the population throughout the year, so that we just have a better understanding in general about the prevalence of asymptomatic cases in our population and the prevalence of immunity in our population, so that we can use that not so much for a diagnostic standpoint for an individual, but really more from a planning standpoint for figuring out, when it's safe to open up more classes or when we need to be, shutting things down more.
Thank you, Dr. Levine. We have an alumna based in London, and warm greetings to all of our alumni and parents who have joined in London. And she asks, what do you think are the main reasons for the UK and the US's inability to manage the testing during this crisis, and thus both countries have had to engage in lockdowns as so many others. What went wrong that we weren't able to apply some of the things that you were just describing a minute ago?
Yeah, I mean, I think that the easiest answer is a failure of leadership, and that is certainly a true answer. But I think if you delve deeper, it's really more a failure of imagination, a failure of preparedness, and a failure to learn the lessons from these other epidemics that the US and the UK have been instrumental in responding to around the world. In fact, the response to the Ebola epidemic in West Africa from an international standpoint was largely led by the US and the UK. Both those countries poured billions of dollars through strong leadership from their governments into containing the Ebola response in West Africa, and to containing it using that simple system of testing, health promotion, contact tracing, and isolation and treatment of cases. And then somehow in the transitions of leadership between 2014 and 2015 to 2019 and 2020, all of that sort of experience and how to control an epidemic was lost. All of that lesson learned about how to prepare for an epidemic that might come to the US or the UK was lost. And, more importantly than that, I think there's a failure of imagination to think that it could even possibly affect us. I mean, it was perhaps this thought that, in West Africa, they have to deal with these emerging infectious diseases because they have these weak healthcare systems. But here in the US, that would never be a problem for us. We have great sanitation and clean water and great healthcare systems, so we'll never have that same problem. When in the reality, we are all as vulnerable to a global emerging infectious disease, and we all need to use the same level of preparedness. Other countries with COVID-19 were prepared and did react. You look at South Korea, you look at Taiwan, you look at Singapore, they quickly identified the first cases in their country. They set up contact tracing and testing systems, isolation of cases, quarantine of contacts, and they were able to control the epidemics and continue to control the epidemics in their country without huge lockdowns. But the US and the UK, as well as many other countries around the world, failed to do this.
We have just enough time for one last question, and so I'll merge a couple of questions together. What are the big lessons that we've learned from all of this, from both these crises, looking forward, and in particular, how can countries be prepared and stay prepared for the next big one, which we don't know what it will be or when it will come?
Right. We don't, but it will come, I promise you that. There will be another pandemic after COVID-19. And these are simply becoming more common and more frequent and more deadly for a variety of reasons: the expansion of the human population, increase in global networks, climate change, expansion into areas that zoonotic diseases typically have been isolated from humans, like forests in the Amazon and in Africa and elsewhere. For all of these reasons, we're going to see more pandemics. And I really do hope that the US and the world at large learns the lessons of COVID-19 in order to be better prepared for the future. So what do we need? We know that we need to have a better stockpile of equipment and supplies, and this includes the reagents that are needed to create any sort of PCR-based tests in the future. We can easily stockpile up on gloves and masks and reagents. That's a simple thing to do. A more complex thing, but still very doable and absolutely necessary, is ensuring that we have the human resource capacity, and especially the surge human resource capacity. Instead of, or perhaps in addition to, a national guard, we need a national contact tracing workforce that, maybe isn't used for the most part on a day-to-day basis, but is ready and trained so that they can be called upon and called up to do massive contact tracing across the US and across the world in the case of the next pandemic. And then ensuring that we also have the surge capacity for our hospitals, not just sort of supplies of ventilators, but additional supplies of the doctors and nurses that are needed to run those ventilators and to care for those patients. That means that we need to deal with the shortage of healthcare professionals we have in the United States, which is a shortage that isn't as severe as some other parts of the world, like sub-Saharan Africa, but is still pretty significant. And we need to ensure that we are spending the money to train up more people than we think we need for the healthcare of our population so that they're ready to deal with a surge of cases in the future.
Well, thank you again, Dr. Levine, for speaking with our international alumni, parents, and friends today. We greatly appreciate your time and all of the terrific work you are doing at Brown to teach students, to give our students incredible opportunities, and to make the world a better place. I want to wish everyone a pleasant and safe weekend. Be well, stay safe, and ever true to Brown.
Thank you so much for this opportunity. And to everyone who's joined this webinar, please feel free anytime to reach out to me, to send me an email. Happy to answer more questions. Love to hear from all of you. Thank you so much.